as a disease we think of sporadic IBM as a disease of aging. When you're over age 40, you're at risk for it. And over time, even the risk increases with even if you're over age 50. But there's some folks that are younger IBM patients where the disease starts around age 40. And unlike other myositis types, IBM does not have a skin rash associated with it. Dermatomyositis has a skin rash, IBM does not. And the weakness in IBM tends to have a certain pattern to it. This is an example from a patient with IBM that can clench her fist on one side, but on the other side, the fingers are so weak that it looks where there may be an obscene gesture here, but that's not the intent here. It's just the fingers are weak. And same thing with this other patient where the fingers are weak. And notice that the weakness can be in some fingers more than the others, and it can be different from the right side to the left side. So we call it asymmetric for that reason. And in the same patient that has finger weakness, when you look at the strength of the shoulder elevation, we call it abduction of the shoulder. That's the elevation of the shoulder muscle that is normal or near normal, whereas the weakness is profound in the finger muscles. Also, the other muscle that's key is not only the arm, actually more commonly, it's the thigh muscle, the quadriceps muscle that's weak. And in this patient, he's trying to extend or stretch his leg straight, all the way straight. However, all you can see is a partial elevation. And notice something. Normally, when you contract your quad, it bulges up as a big, thick muscle. What we're seeing here is the scalloping. Where is the quad? It's melted away, it's wasted away. So quad weakness is one of the features of IBM, and it is usually of similar degree or weaker than bringing the knee up. Bringing the knee up is called hip flexion. This is when you lift your knee up towards the ceiling. So this kind of is a pattern. So when I see a patient in the clinic, I shake their hand, and their hand is weak with their handshake. When their quad is weak and they're over age 40, now I'm starting to think this is inclusion body myositis. When I measure their creatine kinase, the muscle enzyme, it may be normal at times, but oftentimes when it's elevated, it's less than 3,000. I've seen 3,500, but typically it's less than 3,000. And then we do muscle biopsies, but there's also an antibody test in IBM nowadays. The muscle biopsy shows on the hematoxylin eosin stain, which is this panel and that panel, two different things. Evidence of inflammation with invasion, which is this part of the fiber that's been attacked by T lymphocytes, but also it shows these holes in the muscle fibers that are called vacuoles, rimmed vacuoles, because they have a bluish rim around them and this purplish rim in the stain, which is called Gomori trichrome stain. So they're inflammatory cells. The problem with IBM, and this is the challenge in IBM, is currently there's no good treatment for it. There's no treatment that works for it. So we're on the hunt, on the search for a treatment that works for IBM. Now, is the disease because of the vacuoles? Is it the disease because of the inflammation? We don't know. But what we do know is that there's some other diseases, especially SS stands for Sjogren syndrome. Sjogren syndrome is where people have dry eyes, dry mouth. That's part of it. There can be joint issues, but we know that some of the autoimmune diseases, particularly Sjogren syndrome, are associated with IBM. So it gives you the idea that perhaps some of this is an autoimmune disease, but some of it is a degenerative disease where there's a problem with protein processing in IBM, and that's been a challenge. Next slide, please. It's very frequent, as I indicated earlier on. Um, Usually, most patients are over age 60, but about 1 out of 5 IBM patient will have their onset or of weakness, which before the age of 60, 1 out of 5. Now, this is a tricky disease because you have IBM. If people ask you, when did your weakness start? It's hard to tell because it kind of sneaks up slowly on you. You're walking and all of a sudden the knee is kind of weak. And but maybe you have been having some slight weakness before, and your primary care physician or neurologist or other doctor thought, well, you have a little bit of knee arthritis, so that's all it is. Or you thought you were getting older. And so all of these things make the diagnosis of IBM delayed and tricky to make in patients. Now, if you look across countries, across continents, between, say, for example, in Australia, if you look in South Australia, this is the prevalence of it in over age 50, whereas if you look in different regions, uh, it may be lower. In Sweden, it's 2.2 per million. In the Netherlands, in the Dutch population, it's almost 5 per million. The highest prevalence that I'm aware of is from a study that looked in between 1980 and 2019 in Olmsted County around Mayo Clinic in Rochester area. They found a prevalence of 182 per million in people who are over the age of 50. So there's something that's in the environment and in the genes of individuals that makes it where IBM is not the same in every country in the way of how often it affects the population. Next slide, please. So this is going back to trying to understand what causes IBM. We know and we see under the microscope that there's inflammation. We can measure cytokines that are inflammatory mediators in IBM. We can see MHC class 1 upregulation on muscle fibers. We can measure it. It's right there. We can see it under the microscope. We know that the endoplasmic reticulum inside the muscles where proteins are processed is stressed out, and that this leads to dysfunction of protein handling and accumulated misfolded protein, an example of which is in this cross-section of a muscle from a patient with IBM, showing something called P62. And this brownish stuff at the outside of this muscle fiber is this aggregation of P62 misfolded protein in IBM. We know all of these are part and parcel of the disease, but is the origin of the disease, the inflammation? Is it the degradation? That's an important question that's not been answered. So what starts it? We don't know. Well, what about years down the road? What makes the disease continue to get worse? Is it this part? Is it that part? Or is it all of this? This is some of the challenges in trying to get a treatment for IBM, is that while we know some of the drivers, we don't know how important they are at different stages of the disease. Next slide, please. To complicate the picture, as if this is not already complex enough, there's some data that is out there that suggests additional causes for IBM, or associations at least. This is particular to Japan. In Japanese population, there's been a report about higher frequency of hepatitis C in people with IBM compared to those in the Japanese general population. And those that have the hepatitis C and those that don't have the hepatitis C antibody, their IBM is no different. So if you have IBM, if you're hepatitis C positive or IBM hepatitis C negative, your IBM is the same. However, it behaves the same way. However, it's more frequent to have hepatitis C compared to general population. This was shown in Japan, was not shown in any other country. So Not sure if a virus triggers IBM. This suggests maybe a virus is a trigger, but that's the only evidence we have for a viral association. There's difference, as you know, between association or causation, right? This is an association in one country, Japan. Now, the other interesting association that is noted is this finding by Steve Greenberg, a very reputable researcher in the field in IBM, that and then Tony Amato at the Brigham and Women at Harvard Medical School, where they found that in their patients with IBM, a lot of them has these weird cells in the blood, and they have these different markers in them. And the important thing is that these markers are markers for a type of cell called LGL. We say LGL because it's easier than saying T cell, large granular lymphocytic leukemia cells. Leukemia, yes. Scary, isn't it? Leukemia. Is this really what we're dealing with IBM? So what they found is that they can measure these cells in the blood of patients with IBM. Not only that, they found that those cells are in those white cells that are invading the muscle of people with IBM. So then the question becomes over time is, did we start with regular inflammation? And over time, those cells with regular inflammation evolved into that T cell LGL cell, which is a type of cancer, you know. Now she asked me, should I be worried? Should I be checked for it? Yes, there's a way to check for it. But the key thing is about this, how cancer is not the same, right? Some cancer is very slow, some cancer is very fast. This is one where it's so slow that the oncologist follows you for years and years to see if there's a change of behavior. That's number one. Number two, there's no good treatment for it. It's almost like IBM, right? It's the IBM of the white blood cells in a way. So it's not something to panic about, but it's an association that's been recognized that is there. And some of my IBM patients have the T cell LGL. They've had it for many years. They follow with their oncologist. They're doing observation for them because it rarely changes in behavior. It rarely becomes aggressive in the blood. That's the key message. So don't panic. Next slide, please. Now, there was this attempt by Tom Lloyd to try to better understand the IBM, what causes it, and what can change the disease behavior in IBM. So he used something that's fancy. He used what's called a xenograft mouse model. And what he did is he took muscle biopsy from IBM patients and put them in mice, implanted them in mice muscles that are immunodeficient. And basically, the muscles start to grow, the human mouse starts to grow in the immunodeficient mouse, and it shows inflammation, the vacuoles, the P62, TDP3, TDP43 pathology. Then what he did, he went ahead and injected an immunosuppressant called OKT3 in this case. What it does is knocks down the T cells. The T cells are a big part. Those white cells that are invading fibers, these are T cells. So it wiped out T cells. It wiped out the MHC1 that we talked about was on the muscle fiber. But the vacuoles and TDP43 loss of function did not change. They persisted. So it tells us that if you use an anti-inflammatory drug against CD3 cells, T lymphocytes, and knock down the lymphocytes, it may change some of the things, the inflammation, but it will not change those vacuoles that are part of the IBM. Makes it complex disease as we thought originally, but it confirms our thinking that this is not simple as one treatment is going to fix it. It's going to take more than that, I think. Next slide, please. So now to add to the complexity is, I showed you earlier what IBM looks like in a way of a typical disease. Well, this is what IBM is, right? Well, guess what? And maybe some of you have had this. It can present differently sometimes. There have been reports of patients who have had just elevated muscle enzyme, and they end up having muscle biopsy, and it shows vacuoles inflammation. That was like 5 years ago. Then 5 years later, now they develop the weakness of IBM. So sometimes can present early on in the early stages as high muscle enzyme. Camptocormia. What is camptocormia? This is the bent spine syndrome. You've seen patients, elderly patients that walk bent at the waist at the supermarket, that's camptocormia. That can be the first symptom of IBM. We had a case series from KU where we looked at our patients with IBM. About 1 out of 7 started with swallowing weakness or face weakness before they develop hand or thigh muscle weakness. And some patients may present with foot drop, or the weakness can be like that of polymyositis in the shoulder and in the hip muscles. And this is at the beginning. And this is important because some of you may have started this way. What it does to you is makes your diagnostic journey longer because this is not the typical presentation of IBM. Next slide, please. Now, it's also not easy to diagnose IBM. So I know that I say early on, we need to have better diagnostic ability, recognize it early on, but not only can it present in different ways, but it can mimic other things. For example, we published a case series of patients with amyloid myopathy that their weakness looked like IBM, but they had amyloid. Sarcoidosis, the chronic sarcoid myopathy can look like IBM. I've taken a couple of patients out of ALS clinic because they were thought to have ALS, but turned out they have IBM. And there are others listed here that are potential mimics. So it's not an easy diagnosis. Next slide, please. When it is suspected, however, what we do as physicians, as doctors, we do a muscle enzyme analysis. We know that's elevated, but not too highly elevated, the muscle enzyme. We do the EMG test, and we look for the antibody, which is available commercially. Now, one of the things about biopsy in IBM, and many of you may have had muscle biopsies for IBM, is that it's still part of the criteria for IBM right now. But the first muscle biopsy can be tricky because it may not show IBM right there and then. It may be normal. We've seen that in 20% of IBM patients on their first biopsy can be normal, but also it can show only inflammation or vacuoles, not both. Next slide, please. Now, some of us are huge fan of the antibody. Others are less enthusiastic about the antibody. I think it's an important clue in IBM, but should not be viewed in isolation. Why do I say that? Well, if you look at people with other diseases, do they get this antibody to be positive in their blood? Yes, in patients who have Sjogren's syndrome, the dry eye, dry mouth, a third of them will have a positive antibody. A third will have positive antibody. How many of them have IBM? None. Patients with systemic lupus erythematosus, another autoimmune rheumatologic disease. How many of them have a positive antibody? 20%. What about polymyositis? At least 5% of the patient with polymyositis have a positive antibody. In dermato, it's 15% at least. But it's been described in ALS. Therefore, I think that even though we want people to diagnose it, doctor to diagnose it, recognize it early on, it's important to take it in the general bigger context. Is this a correct test to order in the right patient? So if someone has ALS, I would not order this test. It only will add confusion. I would look at the clinical picture. Does it look like IBM? I would rely on the muscle biopsy. Does this look like IBM or not? Next slide, please. So now that we have all this kind of, well, what is IBM? How do we diagnose it? First, it seemed easy. Then now it sounds confusing. I'm going to walk you through two sets of criteria that have come up for classification of IBM. These are the 2011 criteria. Yes, they look complex. I get that. Wait till you see the next set of criteria that we developed in 2023, and we published last year. But initially, we thought IBM could be based on a lot of findings on the muscle biopsy and something clinical, meaning the arm pattern of weakness or the leg pattern of weakness. And in someone who's old enough and has weakness for long enough. Or it could be based on a little bit of pathology on the muscle, but both the arm and leg weakness, or little pathology on the muscle, or either the arm or leg weakness. And this is the criteria called European Neuromuscular Center Criteria 2011, ENMC 2011. So this is the criterion that's currently being used in research study for entry of patients in IBM studies. And if you have probable IBM or clinical pathologically defined IBM or the clinically defined IBM, you have IBM. It's just for classification purposes. Next slide, please. So in 2023, we complicated the picture a little bit. We had a meeting in the Netherlands, and experts from around the world were convened. And these are the criteria. These are the 2024 ENMC, European Neuromuscular Center criteria for the diagnosis of inclusion body myositis. And this is taken directly from that paper. It shows that there's the common presentation for IBM, but now we recognize uncommon presentations. So let's talk about what's common. You have to be old enough, or above 45 or at 45. Weakness is progressing for 12 months or longer. The creatine kinase is no more than 15 times elevated. And then it says that you have one or the other. Either your finger flexion is weak, which is what I showed you early on with those pictures, or the thigh muscle is weak. And the first criteria, in the 2011 criteria, we were doing comparison between the fingers and the shoulder muscles. We're not doing that anymore. And the first criteria, we're doing comparison between stretching the knee straight and bringing the knee up. We're not doing that anymore. We think knee extension weakness is good enough. We think that finger flexion weakness is good enough, one or the other. So this is the clinical part. But then from an investigation to get to the diagnosis of IBM, still muscle biopsy is part of it. And muscle biopsy should show inflammation. So if it shows inflammation and someone has both the fingers and the knees that are weak, and you have inflammation, you are secure. You are already there. You have the diagnosis of IBM. However, what if someone has this pattern, but only the arm finger pattern or the leg pattern? This is the common presentation with finger or knee extension. Then mandatory is good, but you have to have at least one supportive. So we introduced something called supportive finding. What was the supportive finding? Vacuoles on the muscle biopsy, mitochondrial changes worse than what we see with aging on muscle biopsy, the antibody to IBM, and we introduced MRI imaging appearance of the muscle in IBM. Could be ultrasound, but we prefer MRI. Now, this is the common presentation. What about the uncommon presentation in IBM? Well, we recognize the fact that some patients may start before the age 45. The disease can be less than 12 months as we get better in diagnosis it. I've mentioned to you earlier that I've had patients with CK of 3,500, so the creatine kinase can be higher. Sometimes the weakness is in the bent spine weakness, like I showed you early on as a confounder. Isolated dysphagia, we reported that years ago. Foot drop, we also reported that years ago. Facial diplegia, that was part of what we reported. Proximal limb weakness, it looks like polymyositis sometimes. So if it is an uncommon presentation, we don't want to miss out on the diagnosis of IBM. How do we get there? We still have to have the inflammation on muscle biopsy, but now instead of one supportive criterion, you have to have two. You have two supportive criterion. And then there's something that is a caveat about IBM. For example, you don't want patients with IBM to have a positive family history because here we're talking about sporadic disease. And if the EMG is not consistent with IBM, like showing something that looks like ALS, it might be ALS. And if someone has a positive Jo1 antibody or other myositis specific antibody, this is not likely to be IBM. That gives you red flags. Next slide, please. I know I only have 5 minutes. We have to go to questions. So exercise. I hope all of you exercise because there are three different small studies that consistently show that exercise is A, not harmful to your muscles, B, is helpful. Now, what exercise is good for you? I know we have a session for physical therapy. When it comes to IBM, it's mild to moderate intensity, low repetition, 10 to 15 repetitions, non-fatiguing exercise that's recommended for IBM. Now, this is for weakened muscle with IBM. I have patients with IBM that are still strong in many muscles. You can push harder in the stronger muscles, but in the weakened muscles, I recommend, you know, that you do in the weakened muscles, scale down on the intensity and the frequency of the exercise. It's good to have the exercise done daily, especially if you're not noticing a downward trend. But if you're noticing something, you should do it every other day to figure out how to tweak down the exercise. So something to work with your physical therapist on. Now, typically they like to push you hard. You don't want to push hard in the weakened muscles, but in the strong muscles, you can push harder. All right, next slide, please. Now, we probably want to hear more than exercise. These are studies, bunch of studies. I'm not going to go through each one of them, just to say that we don't have yet a treatment that works for IBM in the way of a pill or injectable drug for IBM. Next slide, please. This is the study that I led. It was an international study looking at a heat shock protein inducer in IBM. You can see the graphics showing the change of IBM over time in the placebo and in the medication group, and there was no difference between the two groups. Next slide, please. This is the study by Olivier Benveniste, a French investigator at Salpêtrière, who tested a drug called sirolimus because it blocks the T cells. It also improves the mitochondria and allows for better clearance of the proteins. And he showed that there were some indicators of positive signal on some of the metrics of IBM. Patients could walk a further distance on the 6-minute walk test. Their breathing test was better. The MRI imaging was also better of the muscles, and the health assessment questionnaire was better. Next slide, please. This is from, for that, right now, just to kind of tie up the point, is that there is right now an international study that's going on looking at sirolimus and inclusion body myositis. Now, the other interesting finding is also by Dr. Steven Greenberg, where he kind of tried to characterize the white cells in patients with IBM. And if you look at the white cells, there's something of a receptor marker called killer cell lectin-like receptor G1. And this is a muscle biopsy from patient with IBM, and the dark staining cells are the white cells, and they are expressing this marker. We call it for brief KLRG1. So it turns out the T cells around muscle of patients with IBM are positive for the KLRG1. What does it mean? Well, KLRG1 characterizes cells, we call them TEMRA, terminally differentiated cells. These cells are very hard to treat with any immunosuppressive agent. Well, a study's going on right now trying to tackle these cells. There's an antibody that was designed for the KLRG1 for these specific marker on these hard-headed T cells. And at Curo is running right now a study that completed enrollment that we're hopeful in the next year or so to have the results of. So it's exactly at the top of the hour. I think this is my last slide. I'm going to stop here and answer your questions.
Okay, I'm checking the chat to see if there's any questions, and there's not there. So if you guys have questions, you can unmute yourself. And you can usually do that down at the bottom. There will be a little audio mic icon. So you can do it that way as well.
Dr. Dimachkie, this is Malati in California. And I'm wondering what's in the pipeline to address the degenerative components of IBM. If indeed ABC 008 works, we don't think, as I understand it, that's going to be enough. Am I correct?
I hope I'm wrong, that it will be more than enough, that it stabilizes, maybe improves the disease in IBM. But I'm a bit of a skeptic overall, and I like not to put all my eggs in one basket. So from that standpoint, I think that we need other therapies that would be in development for IBM. So from a pipeline standpoint, I think that having an idea as to whether sirolimus that works through different mechanisms, not only inflammation, but works on the mitochondria and also works on the protein aggregates, whether sirolimus is effective in IBM is important. I think that there are other approaches that we're exploring that's still under confidentiality, looking at different targets within that diagram that I showed you that are in early stages. There are some studies going on, and I have one of the studies that completed the enrollment, a safety study of stem cells in IBM. Some of you may be excited about stem cells. We're doing that. We're also doing other studies because right now the measuring stick for success in IBM is this 10 item questionnaire, the IBM FRS. It asks you one question about swallowing, 3 questions about your arm function, 3 questions about your leg functions, and 3 questions about your general body functions, turning in bed, positioning sheets, getting up steps, walking. And with that in mind, I think that it is important to have a metric that's a bit more reflective of the lived experience of IBM. So we're working on measuring disease activity in the home setting using biosensors that measure arm function, leg function in patients with IBM. So we need to do better in measuring how disease moves over time, number one, but also we need to target multiple mechanisms of action because I think if I compare IBM to something like ALS as a disease, they have a lot of similarities. And I think it's going to take multiple different treatments, a cocktail of treatment to get to a place where we can stabilize or improve the disease.
Thank you.
Welcome.
And then I do have some chat questions. So are there any studies showing IBM relationships with celiac disease or vitamin E deficiency?
I'm not aware of studies showing association with celiac disease or vitamin E. I think what I've seen in the way of association, vitamin E deficiency, when I think of vitamin E deficiency, I think of from a neurological standpoint, the manifestation is a neuropathy and which is nerve damage, and it causes balance issues as a result of that. Um, it can cause jumpy reflexes too. When I think of celiac deficiencies, I've seen patients with concomitant autoimmune diseases, meaning one autoimmune disease associated with another. We know that from, for example, celiac. I've seen patients with CIDP and celiac. I've seen patients with myositis and celiac. Is it cause effect, or is it that the genetic makeup predisposes us to have autoimmune diseases? In this case, not one, but two. So that's my answer to your question. But as far as generally speaking in the literature, I'm not aware of associations.
Okay. And then what about can Vertex help with IBM periodic muscle pain?
Vertex. What is vertex?
I don't know. Mom,
Uh,
I'll Google that really quick. And then
no, no,
another,
that's
you know,
okay. Maybe we can have the person that asked the question unmute and explain what vertex is. I'm going to learn from you.
I asked the question. The FDA just approved this new non-opioid, supposedly pain pill. It was in the New York Times yesterday or the day before, and I just wanted to know if it could help with muscle pain, but I guess you'll have that for another lecture when you've had a chance to look into it.
Thank you so much, Maureen, for your question. I always learn from my patients when they ask and challenge me with things that I don't know about. I think this may it's worthwhile looking into. It comes down to side effects, what's available in the way of alternative treatments, and what is it approved for. But it's exciting to see that there are more medications coming out, even outside of IBM. Thank you for your question.
and then I'm going to combine a couple. So if onset is early in life, is it more aggressive? And then can patients get off-label treatment of meds to help with faster progression of IBM?
Yeah, as far as younger age of onset, does that predict a more rapid progression? Um, I've, I don't know that we've studied it carefully so far. When I think of my younger IBM patients' trajectory at times, and even in the older patients, but in the younger patients, like the around age 40, I've seen it at times act a little bit more aggressive than those that are more aged. But I don't think there's a good study out there that tells us about the difference in age of onset and behavior. The second part of the question is, Ali, different a little bit?
It's about off-label medications for treatment.
Off-label. I wish there was an off-label option for treatment in IBM. In my patients with IBM, I just don't have that. Um, I don't discuss that option. So unfortunately, there's not an option for off-label treatment that I'm aware of.
Okay. And then is there a way to tackle cryptic proteins related to TDP43 related to missplicing?
It's an interesting question. I've been interested in that approach too. Someone must be very sciencey here in the audience. And then, but uh, because of some of it is mediated by that mechanism, some of the IBM, I've explored, not so successfully so far, the possibility of targeting that part of the disease in patients with IBM. But it's worthwhile pursuing it, I think. I believe other investigators may be pursuing it.
Okay.
Any
And
sorry,
CAR T
is there
therapies
any?
is a question. Yeah.
CAR T is the next question. I think CAR T is an exciting way to think about it. Is that's the question, right, Ali?
Yes.
Okay. So when it comes to CAR T, the way CAR T works, it works on targeting either B cell maturation antigen or CD19, which are markers on lymphocytes. And these are markers of antibody production, basically. And I have targeted classically so far the B cells and different stages of B cells that are antibody producing. So in a way, it does make sense to look at that and examine it in patients with IBM and try to see if you cannot alter antibody production. Now, there's evidence that the antibody is pathogenic from animal models. And for that, um, you know, it's it seems to suggest, that based on what I can gather in the way of the commonsensical information, that this approach should make sense in the way of attacking IBM from the angle of, well, yeah, there's an antibody in about a third to 50% of the patients that may be depleting that antibody level by targeting the B cells at different stages of maturation may be helpful.
Okay, and then we do have a few more questions. Some are about the quality of life questionnaires, if there's better measurements or what those questions are. I'll be talking
Yeah,
about our biosynthetic study in the research portion.
yes, you'll be doing that. And the other thing is that um, IBM is quality of life impairment. Some of the things some of you alluded to in your questions. I have muscle pain with IBM. What do I do? I need a treatment. The Vertex question there is telling me, hey, I'm suffering from muscle pain. What do I do? Is this drug for me? But pain, is it part of the questionnaires that we use for IBM? Or fatigue? Many of you are fatigued because of IBM. Of course, as we get older, we get fatigued, but you are fatigued unlike your contemporaneous aged individuals. So all of these things really tells you these are opportunities, whether it's pain, whether it's fatigue, whether it's quality of life, for us to have better measuring sticks for them. The problem with them, with questionnaires is, and the good thing about them is, the good thing is they bring your experience to light. Yeah, they tell us, well, this is what's going on with them. But the bad thing about them is sometimes those questionnaires, they pin you down between two answers that you don't fit with one nor the other. And you're trying to make your best, trying to fit in one answer. And this is the reason why, when Ali will talk about our biosensor study, this is why we're doing the biosensor study, that trying to, rather than you having to be quizzed and trying to be pinned to make a choice between two different answers, we're trying to measure it in a way where all you do is live your life normally. A week at a time, we measure your activity, and that is analyzed and tells us if your activity is stable, declining, at what rate is it changing, gives us a measure of your disease.
Okay, and then I'm going to combine a couple again. So is CBD helpful or harmful for inflammation with IBM? And then is there any diet or nutrition changes that could help with inflammation?
Yeah. So, CBD. This is CBD. The rules and regulations around CBD have changed and they're state dependent. Some states are very liberal when it comes to CBD. Others require a certain concentration of it. It's topical, it's ingested. They're all different rules. So I start by the answer to the question is just make sure you don't get in trouble with the law. Follow your state regulations. Now, when it comes to beneficial effect of CBD in IBM, some of my patients with IBM or with other neurological diseases will use CBD for pain, and some of them respond to it, others don't. As far as disease itself, does CBD modulate the disease? We're not aware of any information that comes along those lines of saying it does help IBM, the disease itself, but pain, it might. Um, Now, as far as diet and nutrition, um, you know, uh, if you're an average weight, you don't want to lose weight in patients with IBM. If you're overweight, it may be worthwhile losing some weight. Why is that? Is because more weight on your body is more drag on your muscles. As they get weaker, it becomes more difficult to move about. So it makes sense to kind of maintain weight at a reasonable value. You don't want to be a skinny twig, but at the same time, you don't want to be like 300, 400 pounds and try to kind of challenge your muscles even more than they need to. Now, from a nutritional standpoint, I think this is more of the question. It's about whether patients with IBM should take a certain diet. That's high protein help. We don't have evidence for that. Does an antioxidant diet help? It makes sense, but we don't have evidence it helps. So there are some practices out there that you can discuss with your physician as to what diet you could be on. But I'm, for my patients, when they ask me, I tell them we don't know that any of those help.
Okay, and then combining a few more. So I think for the off-label question, was more so for sirolimus. I think some patients are able to get that off-label depending on their treating physician. Um, so I guess that's something people are wanting to know is if sirolimus can be off-label.
Any drug in the US can be used off-label by your doctor, It's something like, for example, in nerve pain, for many, many years, we've used antidepressant medications like amitriptyline or triptyline. They're not indicated by the FDA for the treatment of nerve pain, but they are used off-label for the treatment of nerve pain as long as they're safe to you. There are reasons for them to be unsafe in some patients, but as long as your doctor feels they're safe to you and you're interested in them, you can discuss that. That's a discussion you have with your physician. Of course, whether insurance pays for it or not, whether it is amitriptyline or triptyline or other drugs, is a different question. But off-label use is something that can be explored with patients and physicians individually on a one-to-one basis. It's not like on a global basis where I say, yes, it is off-label, go use drug. It's a conversation you have based on your disease, what comorbidities you have, meaning other diseases. Does this make logical sense? And then comes the economics of it. Is it safe for you? Then it comes the economics of it, of whether insurance does or does not cover it. Typically, with off-label use, insurances make their own mind about whether they're going to have coverage, and I cannot speak for that. But that creates another layer of complexity.
Okay,
I hope
and
that
then
answers your question.
thanks, Dr. Dimachkie. So we will be talking about our stem cell study in the research section, so we can go more over the stem cell stuff then, but um, some patients want to know if there's more research for stem cells. Um,
Yeah,
and
I
I can,
mean, some of the questions that I can read the mind of people maybe on that is, well, is there a next stage study coming up? We're working slowly towards that goal. These are expensive studies that cost multi-million dollars, so we're working slowly towards that goal. And as far as creatine monohydrate, there was an excitement years ago about creatine monohydrate as a supplement and for different things, all muscle diseases, muscular dystrophies and whatnot. And, just make sure that you don't get side effects from it. But the excitement about it in muscle diseases has faded away. Though, again, you cannot be faulted for trying. You have to try something. But creatine monohydrate can damage kidneys if you don't hydrate well with it, and it has other side effects. Always consult with your physician on any supplement or medication that you're taking.
awesome. And then the last one is about possible like apheresis, like plasmapheresis, stuff like that as treatment.
Yeah, plasmapheresis. So some of you may know what that is. I'll explain what that is for everybody before we try to answer it. Plasmapheresis is a process of putting a cannula in your neck area that has two different tubes. One of them to draw the blood out, the other one is to return the blood. And the blood goes to a machine in the hospital. You're laying in the hospital there, you're admitted, and it goes to a machine, and that machine spins your blood down, and then um, you basically return to the patient the white cells, red cells, and the platelets, but the top of the spin blood is the antibodies. That's the plasma. It has all the antibodies. You take the plasma, throw it out, and give patients back a blood product. It's usually albumin or fresh frozen plasma. That's plasmapheresis. Where do we use it in neuromuscular diseases? We use it for myasthenia gravis crisis. Also, it makes sense in any disease where there's an autoantibody that's causing the disease that is dialyzable, that we could consider plasma exchange. I've not used it in IBM In myositis, I've used it in one patient with advanced myositis. She was in the intensive care unit. She was on 4 other treatments for her myositis. She didn't do well. It's a thought. I've not used it in IBM. I don't know that that's going to be a practical solution for IBM.
Okay. And then one last one, and then the rest of your questions we can also answer in my research section too. Plasma-rich injections, like platelet-rich plasma injections. Do
Uh,
those work?
Platelet-rich plasma injections is the fad of the day, right? It can help joints, it can help tendons, ligaments, it can help all different things. And I have patients coming in telling me they paid money for this one and that one, and for different reasons. Now, for IBM, we have no evidence this works. I'm a bit of a skeptic when it comes to PRPP, plasma-rich plasma injections. That's the abbreviation for that. But with a disease like IBM, I see where sometimes, you have to try different things. I know some of my patients have tried even going to different countries to get stem cell injections. And, um, you know, my advice to you is when it comes to those unusual treatments for IBM, talk to your doctor before you do them. Realize that those treatments may not be worth the money that you're putting in them. If they're cheap, if someone tells me I want to do acupuncture for IBM and the session is 25 or $50 and I want to try it for pain, that's one thing. But if someone wants to tell me I'm going to go to South America and spend $10,000 to get stem cell treatment, I'd rather they have a nice vacation and not deplete their resources that way. But everybody can make up their own minds. It's a conversation that you have with your physician. You get their advice. You decide what you want to do. So I guess that's my take on it.
Awesome. Okay. I think the breakout room is going to end here shortly. So I got the rest of the questions, and Dr. Dimachkie, if you're in the research section with me, we can answer them then.
Wonderful.
Okay. Well, I will see you guys back in the main session.
Like we're broken out. Hi.
You are
Well,
in.
I joined the webinar 50 minutes late. I really had been fascinated by the conversation going on, but I'm not really sure.
Mazen Dimachkie has joined the meeting. You are currently on a button. To click this button, which closes the Carolyn Montalvo has minimize button. Close button. Full screen button. Actions available. This button also has an Safari. Mail 900 Finder. Pages. Numbers. Zoom.us. Full screen button. Build close button. Minimize image. You are currently on an image. To begin interacting with the contents of this image, press Control voiceover off. Voiceover on Zoom. Karen has joined. Joyce Asmus has joined the meeting. You are currently on a button. To click this button, which minimize button. Close button. Full screen button. Full screen button.
Hey,
Actions.
Dave, that's being broadcast over the
Default
channel.
button. You are cancel button. Cancel button. Leave meeting leave meeting button. Leave breakout cancel button. Zoom meeting. Zoom meeting. IBM room window. Close button. You are minimize button.
Not speaking intentionally, please mute your line. We can hear some background. Thank you.
Okay. I'm going to start sharing my screen, and we'll get started. So I know you guys also still have a few questions for Dr. Dimachkie as well. Okay, so the first study I'm going to go over is our stem cell study. This was looking at adipose-derived regenerative cells collected from patients to inject in their forearm muscle or their forearm and thigh muscles. So we'll go into that. We are using this device here from Cytori. Basically, this functions as a big washing machine for cells. So we would collect the fat tissue from typically the abdomen of patients, and then it would go down to the lab and be put into the Cytori machine, and it would go in and it would take the fat cells and turn them into stem cells. So it's essentially just washing them a bunch of times and breaking them down that way to become stem cells, which are just cells that don't have an identity yet. So when they are put into the muscle cell, they go there and they're like, oh, okay, now I'm a muscle cell. And they start to function like muscle cells in the body. So we did 2 injections in the forearm and 6 in the thigh. This was either in on the same side or on opposite sides of the body, depending on how the patient's muscle strength tests were. So their strength had to be within this window of muscle scores to be able to be injected. And if they were within that sweet spot for all their muscles, they could choose if they wanted 2 rights or 2 lefts or opposites. So that's how we did that there. And we used our EMG guided needle to do that. So if you've had an EMG before, which I'm sure you guys have, you would hear the popcorn sounds, but it wouldn't be the shocky sounds or the shocking feeling that you would get. It would just be like a deep flu shot, essentially. So that's how we did that there. And then we are currently in the month 36 and 39 portion of this study. So basically, we had 3 groups of 3. So all of these patients were a little bit tapered as far as when they got their stem cell treatment. So that's why we're in this section right here as far as study progress. So so far, we've done several safety checks, and the primary outcome of this study is to prove safety. You might find some efficacy looking at data as well, but that is mainly for phase 2 and phase 3 studies because it's a phase 1 since it hasn't been done in this population just yet. So again, we had 3 groups of 3 there. We have 6 participants still in the study. So once that study is done and data is analyzed, a phase 2 might be in the future, depending on results and funding. Our next study we're going to go over is the sirolimus rapamycin study. So this study did start in Australia and is now going to the States and in Europe. And we have 14 patients at our site, and we also have Johns Hopkins as a site, and they have about 8 in theirs. So this is a phase 3 randomized placebo-controlled trial. So patients are split up into 2 groups of either getting the active sirolimus or the placebo medication. And it's to see if this can block the active T effector cells in the body and slow progression of the disease in that aspect. So this isn't going to make people stronger, but it is the hope that it slows the progression of patients. And then some inclusion criteria is patients have to meet the ENMC 2011 criteria. So you have to be 45 or older for your symptom onset, be able to still walk and get up from a standard height chair, as well as being able to swallow because the pill is pretty sizable. And for exclusion criteria, patients couldn't have any active infections, and they couldn't have any significant cardiac or pulmonary or other musculoskeletal diseases, and they couldn't be in another study or investigational medication trial within 30 days of joining the study or receive IVIG, methotrexate, prednisone, stuff like that. Usually IBM patients aren't on those drugs, but every once in a while we get a couple that are. And then this is the biosensic study. This is the one Dr. Dimachkie mentioned in his talk. So we are looking at seeing if these sensors could track patients' movement and disease progression a little bit better, or at least with a numerical value, as opposed to our questionnaires that tend to be more subjective, which is also a great feature to have. But sometimes it's nicer to have that number linked to your disease progression. This one will have about 20 patients. It's here at our site. Patients wear a pendant necklace and then two, they look like smartwatches, wrist pendants, and you wear those at 7 days at a time. The study is roughly a year long with visits every 6 months. So at each visit, you'll get these sensors to wear for about a week, and then you'll mail them back. This one, you again have to be diagnosed with IBM to be in the study, and be able to consent, and be willing to follow study procedures, and not be in an investigational drug 30 days prior. Abcuro is one of our other studies that we have. It is currently full, and patients are moving through the study process. This is looking at the Abcuro medication. It is an injectable drug, and patients will get their dose based off their weight. And we are in the Part B portion of this study. And there will be an open label for patients after the fact, after the blinded portion as well. And this also looks at those killer cells here, the KLRG1 cells that Dr. Dimachkie touched on. And it again is another drug looking to slow the progression of the disease. Similar criteria. This one does have a weight because it has a BMI restriction. And you have to be able to walk and get up from a chair. So you still have to be pretty mobile to be in this study. And that's so they can track to see if there is a significant change or not within the disease throughout the study. And then exclusion criteria, having severe comorbidities, or having any like other rheumatological autoimmune diseases that could confound results. So that was my quick little spiel about our research. We do have some studies that hopefully we'll have in the future. Cell therapy, I know, is becoming more and more popular within diseases that we have. But so far in IBM, cell therapy like CAR T studies or NK studies are not quite there yet. But if you guys have any questions, you can now let me know, and Dr. Dimachkie can also address some of the ones from the other chat as well.
I've got a question. I've actually got an appointment with the regenerative medicine clinic tomorrow to take a look at an option for stem cell treatments, and I'm wondering where I could dig into a little bit more information about the effectiveness of that therapy at this point.
Okay, I'll let Dr. Dimachkie do that one since you're looking to actually get active treatment for it.
And this goes along the lines of course, off-label treatment. And this is an important question because, when we think of off-label treatment, it comes down to the risks and the benefits and the alternatives to that, right? So the alternative right now is doing physical therapy and exercise. The alternative is participating in research studies if available to you. And then the risks of it. This is where, when you talk with the therapy team, you will discuss what those risks are. And some of the risk is physical risk, and the other is emotional risk. The third one is financial risk, because these are not typically covered by insurance providers. Now, from the benefit standpoint, if you look at the website of companies that have cell stem cells that they inject, you'll see it's a cure-all, whether it is joint disease, autoimmune, neurological disease, multiple sclerosis, Parkinson's. There are all these claims that a stem cell therapy will help or cure diseases across the board, diabetes, etc. So I take these with a huge grain of salt, knowing that we don't know if stem cells help. I know that Ali mentioned stem cells may turn into muscle fibers, but we think that stem cells not only can do that, they probably don't do a lot of that, but they create an environment where there's less inflammation and there's more blood vessel flow. This is all postulation based on the mechanism of action of stem cells. So whether they're beneficial or not is really a tricky question. Now, if you tell me I'm going to go into a research study looking at stem cells and inclusion body myositis, I would say, think of it, look at the risks of the study, and maybe this is the right study for you or not. However, when it comes to trying the off-label treatment with stem cells, I know with IBM, it's a tough situation. I know with IBM, you'll go to an extreme in exploring different therapies. But in this one, I don't think we have the evidence right now to support that it works. And that's why we did the first stage of the study to show that what we're doing is safe, in hopes to expand later on to do a testing study to see in a research study as to whether this is helpful to you or not.
Thank you.
You're welcome.
Doctor, this is Ricky Marks, and I did have a question. In terms of the role of immunosuppressant agents currently in the treatment of IBM or slowing the progression, does immunosuppressants like methotrexate or azathioprine or prednisone, do they really have any role in slowing the progression of IBM? And should they be used, or does the literature support not using those agents at all?
Yeah. You know, immunosuppressive drugs have been tested in randomized controlled trials in patients with IBM. Some of those studies have included prednisone alone, prednisone with IVIG, azathioprine, and others. And unfortunately, they've not shown benefit in patients with IBM. Unfortunately, they have not. I have some patients with IBM that have, for rheumatological reasons, like they have IBM, but they also have systemic lupus erythematosus, and they're on lower dose prednisone, like 5 or 7.5 milligrams chronically. Or some patients who were initially placed by an outside doctor on prednisone for thinking it's myositis. Over time, it became clear they have IBM, and I'm taking them off the treatment, the prednisone, tapering it down. And every time I taper it down, they say they feel worse, around 5 or 7.5. So may I continue them on that, not knowing if it is really helping, but at the same time, when the patient tells me they're getting worse, I have to take it at face value. It's one of those, we do it because it makes sense, but it's not the best evidence-based way of doing things. So generally speaking, majority of my patients with IBM are not on immunosuppressants. Immunosuppressants don't work in IBM in general. There are some reports early on just to complicate the picture a little bit more. So right now, most patients don't get it. Some may be on a low dose because as they were coming down, they felt worse. It's a feeling, so I have to be respectful of that and mindful of that. But then there are the reports of patients who presented like polymyositis initially, and meaning they have weakness in their shoulder area, in their hip area, and are treated with steroids. And then initially, in the first year or two, they get better, get stronger. And after that, a few years later, then they keep on getting worse, and then the hands are weak, as I see in your hands, sir. You have the IBM hands, I can tell the way you're flexing. and then, the patient become refractory to treatment, and the biopsy shows IBM, and it's clear now that they have pattern of weakness of IBM. So they could be in an early stage of IBM in the first year or two, where immunosuppression might work. We don't know that for a fact, but there are case reports of that. So I'm just trying to say, I guess, the quick answer is, generally speaking, these things don't work. Immunosuppressive drugs don't work. Prednisone doesn't work. But they could be an exceptional patient who early on in their disease caught on for what looks like polymyositis, may respond and then develop later on IBM. And it could be the converse. Later on in the disease, someone who's tapered off prednisone but reaches a ceiling dose where if he or she goes below that, they get worse subjectively, but that's something also a consideration to maintain on low dose. It's less than 5% of my patients with IBM that do that.
I do agree with your comment that it's very hard to stop prednisone. In my own case, I got down to like 2 milligrams, and I just had to make that jump and just finally just stop. And prednisone makes you feel much better, but in the long term, I think the complications was just too much, particularly the weight gain. But thank you for your answer. I appreciate that.
Yes, thank you, Ricky, for your question. Weight gain, side effects, that's very important. So let's name some of the side effects of prednisone really, really quickly. Weight gain, high blood pressure, sugar diabetes, leg swelling, cataract, glaucoma, anxiety, depression, poor sleep, being peachy in your mood, snappy at others when they talk to you, ulcers, bone thinning, easy bruising of the skin. Should I say any more? So it can be used with caution. We prevent the side effects. We do it carefully as physicians, but we don't use them willy-nilly. This is where risk benefits alternatives to treatment. This is where the risks of the treatment is important to discuss and explore with the patients. Yeah.
Hi, it's Nancy Marks Harrison. I I have a couple of questions. First of all, on the rapamycin the rapamycin, what type of side effects do you or have you seen with that drug? The second question I have is talking about physical therapy, physical activity, quality of life. Are there any more studies, since currently that's something that we really need to do to try to stabilize our, our IBM? Are there any more studies being done on that, number one? And do they actually maybe slow progression? Can the physical activity also help the metabolic aspect?
Very good questions. Thank you. I was muted for a second. So now I'm back on.
Sorry,
Hard to answer when I'm muted, but I did that to myself. So I think I got most of your questions. So first, sirolimus. We don't know yet about its negative impact in the IBM patient population because the study is ongoing right now. For adverse events that we look for very closely, and anything is possible with any medication. It can affect your lipid profile. It can affect your kidneys. It can make you pee out more urine in your protein. It has a whole bunch of, it's not a benign medication. This is a transplantation medication. So that's why when people ask me about it, I go over not only these side effects, but a whole bunch of side effects from my handheld device where I rattle them out, but also I look at the package insert of the medication, because if you do like sirolimus FDA package insert search, you will see the hundreds of side effects that this medication and other medications have. So if someone has already kidney damage, it would be foolish for me to put them on, for example, sirolimus, you know. So there all these comorbidities and kind of individual judgments when we talk about, you know, the implication is off-label use, right? Of medication. This is where the discussion of when we talk about risks, that's risk based on the package insert. Benefits is unknown. The alternative, we know what the alternatives are. And you brought the question about the alternative, which is physical therapy, as you were thinking about this. And, as far as studies beyond the three studies that I described, I'm not aware of additional studies. However, that what we think and what we hope is what's going on is that we are stabilizing the trajectory of IBM better than its natural decline, that we may be slowing it down some with keeping the muscles healthier. Is it scientific in explanation? Not fully. That data suggests from those studies that there may be some backing up for it, but these are short studies, several months study. They're not a year or 2 or 3 studies which is the life trajectory of the disease for a couple of decades, 3 decades, 4 decades in patients with IBM. So we need better studies. Actually, this is one of my areas of interest, and we're hiring someone to potentially do those types of studies with us in patients with IBM. So important as far as what the current recommendation that I give, and then there'll be more discussion in the physical therapy session. I'll leave it to that discussion at that point in time. But right now, studies are lacking, long-term studies, because IBM is not a 3-month disease.
Thank you. I agree with you wholeheartedly. Thank you.
Very good.
Okay, some chat questions. There's one about being on IVIG for 2 years, which improved quality of life for this patient. So what are your thoughts of IVIG?
I mean, there was a time, but 20, 25 years ago, where patients with IBM were placed regularly on IVIG. We couldn't tell of an effect at the time. Now, currently, when patients ask me about IVIG for IBM, I tell them we have studies that IVIG alone or IVIG with prednisone, studies have been done and it didn't work. At the same time, if someone comes to me and says, I'm getting benefit from IVIG, I try to figure out, again, the question of the risks, benefits, alternatives comes into play. Are they facing any risks? Are their kidneys failing because of IVIG? Are they developing other serious reactions to IVIG where I need to interrupt the treatment? Or is this shown to be beneficial in a measure that I can physically assess? Let me tell you why. You don't know dermatomyositis, all of you, more than 100 of you that are here. You don't know dermatomyositis, but you've heard of it. But by show of hand that I can see on the screen, who of you thinks that dermatomyositis patients, when you treat them with IVIG, they get stronger? Yeah. I mean, patients with dermatomyositis, when you treat them with IVIG, they get stronger. Now, there was a study of IVIG of patients with dermatomyositis. I was one of the co-authors on this patient paper in the New England Journal of Medicine, where we studied IVIG and dermatomyositis. Patients with dermatomyositis got better on IVIG. But in that study, it was a placebo-controlled study. There was a placebo group. You know what the response rate of the placebo was? Meaning improving patient that got placebo. You know how many of them improved on placebo? Somewhere between 20 and 50% improved on placebo, depending where you put the benchmark of the response. If you look at moderate response, it was 20% placebo response. If it was at least mild response or better, the response rate was closer to 40, 45%. the placebo response. Of course, the IVIG patients did much better. It was 70, 80%. But I guess going back, why am I talking about all this? I'm saying that I guess what I'm trying to say is this. Even when we use measures of treatment response that we think are good measures, it turns out that patients can respond to placebo, right? Now, having said that, some patients may have different bodies, different responses. How many of my patients are on IVIG? I don't have any on IVIG. So it's interesting observation as to someone who feels better on IVIG. I wonder how much of it is objective, but it could be objective. Studies have shown we have a placebo effect. I'll leave it at that without delving in further.
Hi.
Okay, and then
I don't know.
polymyalgia,
Right in the middle of
someone
a
had that in 1998.
presentation from the
I think John is trying to say a
National
question.
Science
Can we give him a chance?
Association, but
Yeah, sorry.
it's 5 hours long, so I figured I could take out 10 minutes. So, let me walk away.
Yes, John, go ahead. We can hear you.
It's a group, TMA.org.
Hey, folks, would everybody please mute your mics, except John?
John, if you have a question, please speak up so that we can answer it and hear you well. Maybe John doesn't have a question. Sorry, go ahead, Ali. And I know Don has his hand raised. Should we go to Don first? Why don't we go to Don first, and then we'll come back.
Can you hear me okay?
Yep.
I thank you, sir, for being here. I posted a question earlier. I'll put it right back in here so I can remember it. I'm a little bit new to this. I'm certainly new to your group. My total creatine kinase 782 as of about a month ago. I'm confirmed IBM biopsy, vacuole was present, ragged red fibers, which I believe are mitochondria damage. And taking the monohydrate orally, I don't see as being beneficial. I also think that exercise, I believe, well, how do I get the inflammation down is what I really want to know. How do I reduce those levels that's been like that for 2 or 3 years, maybe longer? And how do I get it down? It's not improving. I was told by someone that it will eventually go down, but that doesn't seem to be happening. And that's the primary question.
Yeah. So the muscle enzyme is 782. Normal muscle enzyme is 200. This is elevated about 4 times above the normal limit. In patients with IBM, 80% of the patients will have an elevation between 2 times and 15 times, and you fit within that majority of patients with IBM. What I tell my patients with IBM regarding the muscle enzyme is to ignore it because there's no treatment for it as such. Now, if you look at the older studies that were done with prednisone alone or prednisone with IVIG or IVIG alone, in those studies, even though the muscle enzyme went down, the patients did not fare better or did not stabilize better when they got them. So I like all my tests to be normal. I like my cholesterol to be normal, my triglyceride to be normal, like my muscle enzyme to be normal. And I hear your frustration. It's frustrating to see something that is coming from the muscle showing deterioration, and you cannot fight it right now with a treatment to reduce it. My advice to you, even though you may find it difficult to swallow as a pill, is to ignore that blood test. I would worry about it if it was 10,000. I would worry about it if it was 20,000. At this degree of elevation, this is par for the course when it comes to IBM. And right now, we don't have a treatment that targets the muscle enzyme alone. or targets the IBM that works. We kind of are doing the studies. That's what we're doing right now, the research studies to try to find a treatment that helps people with IBM.
Okay, thank you, Doctor.
You betcha.
Okay, and then
Excuse me, is there going to be a session later on concerning physical exercise as relates to IBM?
yes.
I came to the seminar late, so I don't know if there's going to be a further session where we look at the effects of exercise on IBM.
Yes, we have a physical therapy portion for IBM.
Okay, I will hold my questions till then.
And this is coming up actually right now. We're in the IBM research session. After this, there'll be a 5-minute break. Then we'll have a session on swallowing. And after that, there'll be 2 breakout rooms, one for IBM exercise and one for all the other exercises. Okay?
And then
Yes, thank you.
Mhm.
If any of your questions were missed, I put my email in the chat so you guys can email them there. But this last one, is there any connection with long-term use of prednisone with like IBM cause?
This is a good question. Maybe I'll just try to phrase the question a little bit differently, and that could be the intent. Does chronically using prednisone worsen IBM over time? Do we have proof for that? And the answer, I have 55 seconds. The answer is we don't have definitive proof from a moving forward study. There's a looking back study, a retrospective study between the Europeans and the France and the UK. Yes, sometimes they collaborate, even though they were fierce enemies over the decades and centuries. A study looking back at records of patients showed that those who got corticosteroids fared worse than those that didn't get corticosteroids. But the question is unresolved because did they get corticosteroids because they were worse off already, and that's why they got worse overall, or was it just the effect of steroids? Generally speaking, there's a suspicion that steroids may make you worse. I sometimes see it, rarely, in patients with IBM. I take them off steroids, they get stronger. So that's something to keep in mind. Sorry,
Yeah.
Jane, we ran out of time. Did you want to try me? I'll try to.
Yeah, I don't want to go into great
therapist, you know.
I don't want to go into great detail, but I had a cricopharyngeal lobotomy back in 2014 down at Johns Hopkins. It is now back again. I've just seen a new ENT up here in Bethlehem, Pennsylvania. And basically he's saying all of the muscles in my throat, food is just going down by gravity. Every point there's issues. But my main shock question is gag reflex. They said I had no gag reflex.
And let me ask you, have you ever had a gag reflex as a young girl?
Yes, I'm sure I've had.
Some people are born without a gag reflex, you know, that's one thing. So IBM does not affect your gag reflex as such. However, IBM can affect the cricopharyngeus, make it stiff, fibrotic, replaced by scar tissue, makes the flow of food difficult, constricted, especially big pills, but doesn't necessarily trigger your gag reflex, just FYI.
But gag reflex basically is to help block so you don't have anything go down into your airway, correct? Is that what
gag reflex is different? This is when you're gagging on food, whereas there's the epiglottis that kind of shuts down when the food is going down. I don't know if he's referring to your epiglottis or not. It's kind of where the devil is in the details.
Right. Well, okay. No, I don't want to take any more personal time. Thank you.
You're very welcome. Sorry we couldn't do it in the main session, but I'm glad we got to it now.
Allie, will you be able to share my my slides?
Yes, I will share your slides. We are
Thank you.
going to give it over to Claude. She's a physical therapist who specializes in myositis. She's going to give a talk on physical therapy and IBM. And
Thank you.
Mhm.
Should we wait a little bit before I start, or
No, you can go ahead.
I can go ahead? Well, hello from South Dakota. So usually I practice in Kansas City, Kansas, but today is junior day as SDSU in South Dakota. So my background is my hotel room, and I am going to talk about exercise guideline with IBM. Next slide. So one thing that you really have to take into account is that physical inactivity and sedentary lifestyle can lead to disuse. So when we talk about IBM, I know that there is a decrease in your muscle function, but there's also could be a disuse, and that's what something that is going to be detrimental for you. So not only your IBM, but your physical inactivity can really contribute to the fact that you can be weaker. So exercise is important as an intervention that addresses if you have low level of physical activity. Next slide. So there is, like Dr. Dimachkie said, there is no good research with physical therapy and IBM. And the clinical or the guidelines that we use is the general guidelines for physical activity. So 150 minutes of cardiovascular, and then 2 times per week of strengthening. But it's the fashion that you're going to do it that is going to be different in a general population compared to the IBM or with people with IBM. Next one. So, like I said, to this date, there is no guideline that has been established for neuromuscular disease. There's been a few research studies, Wallace and al., Johnson and al., and that have looked at physical activity. Those studies are very low in your population, so 17 people, 7 people. And the length of time of those research is really short. So it's not covering your lifespan. But all of those research have shown the beneficial effect of physical activity. Next slide. So what should we consider as exercise? So it's 4 main groups that we are going to look at. And again, it's the same as in the general population. So your spouse can also exercise in the same fashion as you are going to exercise. So we're going to look at flexibility, at strength training, at cardiovascular, and at balance is also another group. So balance is not often talked about in the general population, but it's something that is very important and something that I look at pretty much every day. Next slide. So we want to stretch large muscle group. We want to hold the stretch for about 30 seconds and no bouncing. So if you're getting into the stretch, you want to just hold and not go like bounce, bounce, bounce into that stretch. And it can be done more than once a day. So there's no problem with stretching more than one time, or even getting your session in little bits of practice. And that's important. It's like having, instead of thinking about doing everything at the same time and being so fatigued after, you can think about having like little bites of exercise during the day. Next one. So muscle group that needs to be stretched. So hamstring. Hamstring is the big muscle in the back of your leg. The quadricep is the big muscle in the front of your leg. And then the hip flexor is what is between your thigh and your torso. Calf is really the back of your bottom of your leg. You should think about your shoulders. You should think about your wrist extensor and flexor, and then even your fingers. Next slide. Next slide is strengthening. So if you went back to the first part of that presentation, I said 2 times a week, and how it's distinguished between you and your spouse or other people is how you're going to use the weight. So it's going to be lightweight, light resistance. We are not going to like go and get some big muscle on you. It's going to be generally to try to first, if you were inactive, strengthen a little bit, get more of the strength back, and then maintaining as long as you can, because that strength is going to affect your function, how you can get out of bed, how you can get out of your chair, how you can get off of the toilet seat, right? Those are all functional activity that need strength, and we need to be able to keep as much strength as we can so that you can function the longest with what you have. Again, when I said it can be little bites, so throughout the day you do little bit, you can also think about dividing your body between like the upper body. So you would do one day, do all of the upper body strength, and then the other day, all of the lower body strength. Next one. We know that in most cases with IBM, the proximal leg, the quadricep, that big muscle in the front of your leg, is something that is going to be really weak. And then your distal arm, so the finger flexor, are also going to be weaker. Next slide. With that said, when we think about strengthening the muscle, we want to strengthen the hip flexor. Now I'm going to stand up and hopefully we can see me. It's difficult for me to talk about muscle when I'm sitting and I'm not showing you. So bear with me. Here I go in my room, my little room. So here we go. So the hip extensor is that muscle here. So that's your hip extensor. This is the one that is going to be used to stand up. Then the knee flexor is that hamstring in the back. So that motion here, hopefully you can see, hold on. We are going to hip flex. So that is that muscle right here. The knee extensor is that big quadricep in the front. And it's, if I go and sit down, this is the one that does this movement. It also helps in that standing up motion. Oh, did I mix something up? Sorry about that. I demonstrated the knee flexor instead of the hip flexor. My bad. I will blame it on my bifocal. All right. So I'm getting a little older. So forgive me. Hip flexor is that motion here, and knee flexor is that motion here. You're going to think this therapist doesn't know our muscles. And then plantar flexor is the one that you use when you go tippy toe, you know, like when you go up on your toes and down. Next slide. So what can we do? What exercise? And we'll talk a little bit more about the role of physical therapy. Those are just general exercises. So squat or supported squat or sit to stand. So Here we go again with my computer. So that sit to stand is a good exercise. Your supported squat would be something where I'm going to hold on to something and I'm going to do a little squat. If you can still do the squat without support, this is what it's going to look like. We can do some standing marches. I better not just, I'm going to put my chair away. So standing marches, right? We can do also lying down. Imagine I'm lying down, I'm going to bring my knee to my chest and bring it down. And then we're going to do some side stepping. So I'm going from side to side, side to side. Therapists can also decide to give you a light band to make it a little bit more difficult. Step up, I cannot demonstrate here, but if you can imagine that you're at your home and you have a step and you can hold on with a rail and just stepping up and stepping down. If you have a small stool at home, you could also do that with the counter in the kitchen. And then calf raise is what I demonstrated before, going on your tippy toe and down. Again, you can use a counter to help you go on your tippy toe and coming down. Next slide. So in terms of upper body, your upper back is very important for your posture. Your shoulder flexion is this right here. Your shoulder abduction is going up like this. Elbow flexion is bringing food to your mouth, right? So that's that elbow flexion. Elbow extension is like this. Reaching up above, we'll use some elbow extension. And then your wrist flexion and extension are these. Next slide. So some example of those exercise, a mid-roll. So if I am sitting right here and I'm bringing my hands back like this, and if I had, imagine I had a little bit of resistance with a band, I could help that. But even air mid-roll would be good. An overhead press would be something like this, where you're going above your head, a bicep, a lateral raise here, like such. We can do bicep curls here, and we can do tricep extension like this, or just even reaching above head, and then we can use our wrist. Next. Cardiovascular training is the next one. So at least 3 times a week, about 30 minutes. And you're wanting to do very like moderate intensity. So what does that mean? It's 50 to 80% of your max heart rate, or moderate to low vigorous intensity on RPE. So next slide, please. So target heart rate, how to do that. So the formula is going to be your 220 minus your age, multiply by 60%. So the example would be, I'm not 50 anymore, but let's say it's 50. So 2 is 102. So how can I do my heart rate? Different thing. You can have a smartwatch. You can invest, if you want to, on a wearable heart rate monitor. You can also do it the old-fashioned, either with your wrist or here at the jugular, and just count. Usually we count for 10 seconds and we multiply by 6, and that's going to give you your heart rate. Next slide, please. This is an example of a Borg scale, what I would use probably in the clinic. And what you want to do is you want to go into that green, moderate, or even into the blue. So from 2 to 6. 6 would really be the maximum that I would want you to do. And you want to really be conscious about it. You know, before we would say, if I can walk and talk, it's a good example. I prefer to like really look at that scale of 1 to 10 and say, hey, how much fatigue am I feeling right now? And if it's too high, that means you either lower the resistance of your machine, you stop early, you take a little break. You could also say, you know, we said about like the three times a week, 30 minutes, and it doesn't mean that you have to do the 30 minutes at the same time. It could be a 10 minutes at one time, 10 minutes another time, and 10 minutes another time, or 15, however you want to do it. There's no rule.
I think we've lost the audio, at least on my end.
Yeah.
I think we lost your audio. Are you still there?
Sometimes the trick is to turn off the video for all the energy to go to the audio. Claude. It might be a bad connection we have. Uh, Ali, I suggest if we could message Claude in the text messaging or the chat, let
I
her know
sent her a
whatever.
message.
Okay,
Awesome. Thank
I
you.
think I'm back.
Yeah,
Am
we
I
can
back?
hear you. Yes, you are.
Oh, it's never without a little bit of a problem for me. And everything froze. Both my computer and my phone froze. So I guess South Dakota is too far. There's nothing here except for planes. All right, Ali, can we move on? There we go. All right. So what are the best equipment? I like those equipment because you're in sitting, you're not in standing, you're not having to engage more of your balance. So the recumbent bike, the new step, or the recumbent stepper are the best one. Next slide. So balance, when thinking about balance, you want to think about doing it in a safe environment. And I will tell you that a bathroom is not a safe environment, because if you think porcelain versus brain, porcelain will always win. So make it safe. You can be done daily. You choose one exercise to do daily. You practice a little bit, and you can use external support to assist you in trying to move away from that external support. Next one. So balance example would be standing feet apart, eyes open, eyes closed, shifting your weight from side to side, shifting your weight forward and back, stepping on one foot forward and stepping back. You can be tapping a foot on a step. So if you can imagine yourself in front of your stair and just standing on one leg and tapping the foot on that step and then switching. And you can stand in tandem. And what it means is that one foot is in front. So if you're not able to do one foot in front, you may want to try to do one foot to the side and work your way to the front. Next slide. So here I am. What is the role of a physical therapist? Because this was really an overview of what you want to do. But really, a physical therapist can be a good adjunct to your treatment. Next slide, please. So first of all, they can evaluate you. They can look at your ability. They can look at what kind of things that are missing. Looking really at your muscle strength and creating a plan that is fit for you. So instead of a blanket, really looking at what is needed for you. They can also work on alleviating your disability. So we always talk about, in the world of physical therapy, can I alleviate, so remediate, or do I have to compensate? So remediating would be, with the exercise, can I go back to my previous level? Or compensating, hey, I do not have the ability anymore. How can I compensate to get me back to where I want? So for example, I'm not able to walk as steadily as before. I'm at risk of fall. What kind of equipment can I use so that I'm going to be safe? So that's one way that we can do this. And the next one will be to decrease, to assist in trying to determine what equipment you need at this point. Next one. So some of the assistive device, those are example, but I know that the world of canes out there is out. Yes, it's really a lot. So there's a posture cane that you're going to hold on higher in your hand so that you're going to be in standing. That can be good, but it may not be for you. Then we have the hurricane. The hurricane has more of a base that when you stand the cane stands by itself. So it can be useful that way, but it's also because the base is wider, it gives you more support. And the one that is on the other side is a cane that can assist to stand. And you can see there's a little projection to the side so you can push to stand. Next slide. Other assistive device are walkers. So different kinds of walker. There's a tall walker, there's a four-wheel walker, there's a regular walker. The one on my side, it's the right-hand side, it's the easy and fold walker, which is good because it folds so that you can go upstairs with it. And then there's two kinds of roller walker. So one thing that you may want to think about when choosing a walker, and again, the physical therapist can help you with that, is do I need a seat height that is higher because I can no longer stand up easily? So if my seat is higher, so if I have a four-wheel walker, my seat higher, it may be better. Do I need some lightweight because my caregiver needs to bring it in the car with me? So all of those things you have to think about and make sure that maybe discussing with the physical therapist would be better. Next slide. Then we look into orthotics, what we call an AFO, ankle foot orthosis, which are going to be the shorter one. And then the KFO, which is knee, ankle, foot orthosis. And then they can be helpful, especially if you have a knee drop or your leg you have more of a imbalance, so one leg really stronger than the other, it may be useful to have something that locks that knee that is more helpful. That is really more the role of your orthotist and your physical therapist. Next one. Oh, there was reference and then questions.
Okay, so I will open it up for people who have questions for Claude.
Yes, hello.
Hi.
Hi, this is Terry. I'm calling from Clearwater, Florida. I have been
warmer there than here.
Oh, definitely. It's going to be 80 today.
Okay.
I have been doing I've been doing BFR therapy for the past 5 months. Thoughts on that type of therapy?
Tell me again the therapy that you're doing.
Flow
Blood
restriction.
flow
Oh,
restriction.
blood flow restriction. You know, there is not a lot of research on blood flow restriction. I've seen one, and the jury is out on it. I don't think it is necessarily, I don't think it's detrimental. You need somebody who knows how to do it. And if you have a good physical therapist that can do that with you, it's good. Yes.
Okay, great. Thank you so much.
You're welcome. Hi, Ricky.
Hi. Thank you for taking my question.
Yes.
At one time, I used to see a physiatrist, and he had a term that that train has left the station. For many of us, that train has left the station in terms of being able to do some of the exercises that you talked about, walking, standing, lifting your legs, and so forth. So I'm currently working at a clinic that has students that come in, and I work with the students, and it's interesting how we go through the process of adapting common exercises to a person that's confined to a wheelchair. I just would like to get your opinion on, is that the best approach? Again, just your opinion on that.
Yeah.
Adaptive exercising.
So I like the train at the station. Yes, it's working with a physical therapist, either intermittently or in a regular basis, is good because the physical therapist should be able to modify your exercise in accordance to your abilities. So yes, if you can still do exercise in standing, it is the best thing. But if you can, then therapists should be able to modify it so that it is perfect for you. So we know, first of all, we know that nobody is the same. Nobody in the world is the same. Nobody with IBM is the same. And that's why I think that what I wanted to really show is, yes, exercise is important. And those are type of exercise. But my advocacy is really to go and train with a physical therapist that can modify accordingly to your abilities.
Okay.
I think that the main what is the word that I want? Sorry, Ricky. What I want to convey is that exercise is important even when you have some weakness.
Okay. All right. So we're on the right track then, because like I said, it just
you are on the
happens
right
that
track.
yes, we're on the right track. Okay. Thank you for your comments. Thank you.
Yes. Marvin.
Hi, I was on the swallowing question as well before, but
yes,
I am in my third decade of IBM, and somebody is talking. Okay. Anyway, I consider myself a slow progressor, and there are also rapid progressors in their course of IBM. Has there been any work at looking at whether or not the exercise slows it down or not?
So again, I think that the one thing that is missing is longitudinal research on the effect of exercise. Everything is so short, and we don't have good research on the effect of exercise long term in terms of keeping as much of your functional ability as we can. I'm biased. I'm a physical therapist. I went into that career knowing what I wanted, and I specialize in neurology, and I have this mindset that exercise is beneficial no matter what. So I see from ALS to IBM to Parkinson, And with my patient, I think that for all of their stages, I think that it is important to exercise to just counteract the disuse. Because if we look at some
You're starting to freeze up again.
deteriorating naturally, right? Have on top of that something that is eating up at your muscle, that progression is even faster. So yes, I'm biased, and I think that exercise in the long term is beneficial. Is it really, like we say in Parkinson disease, that it has a neuroprotective effect? I'm not sure for IBM. Does that answer your question?
Well, there aren't any studies,
Yes,
what you're saying.
there are no studies.
Right.
But I think that if you are an exerciser yourself, you have seen the benefit of exercise at this point.
Well, I did it early, but not so much in the recent years, and I still think I'm a delayed progressor.
Professor,
Okay.
I would encourage you to exercise as much as you can with your abilities.
Okay. Thank you.
You're welcome. Sharon, you had a question?
Yes, I wanted to check about your feelings regarding using a vibration plate for people who
Yes.
are in a chair. So using the vibration plate while seated, are there benefits and or any contraindications?
Let's talk about contraindication first. So I do not believe that there is any contraindication to the vibration plate. However, there is, again, the world of IBM, and I would say the world of neurology in its like complexity. There's no research, because I've looked into it also for Parkinson's disease and for ALS, and there's no research that really shows any benefit from it. With that said, we know that there's no contraindication for it. And if you feel that it is beneficial for you, placebo effect or not, that is what counts. That's what really should matter. Does it replace really the role of exercising? No, it doesn't. But if it's beneficial for you, I would say go ahead. I would, when I have patient coming in a clinic, I will not say anything negative about those kind of what I would call adjunct exercises or adjunct modalities.
Thank you.
You're welcome. Stephen?
Hi. Great presentation, by the way. Thank you so much. I was just going to vocalize a question that one of our other participants, Jane Crushman, asked, and that was your thoughts on aquatherapy?
Aquatherapy, I think that is great. You have to, fatigue is part of what you're feeling. So if you're going to do aquatherapy in a very warm pool, which is much more comfortable, it may take a little bit of your energy away because of that warmth. But exercise in the water is a good thing because it supports, first of all, it supports your body weight, and movement in water is much easier. So yes, for aquatherapy or any exercise, really thinking about those principles that we talked about fatigue, right? I would use the Borg scale, so staying between 3 and 6, and really thinking about safety. That's the two things that I would really say about this.
Sure.
Good question.
Thanks.
Yes.
Hand.
Jane, did you have a question?
Yes, I was just clicking on to raise my hand. Warm water for the pool. Our pool here is about 80 2 degrees.
Mm-hmm.
And I always thought warm water was better for the muscles.
So, yes, it's a balance act, right? If it's too warm, it's really going to, excuse my language, suck your energy out, right? If I think about myself when I go in warm water and I exercise, it does fatigue. Well, it relaxes me, but it fatigues me more because that water, that heat really took something out of me. So I would say too warm, not good. Too cold, then you're freezing and you're like contracting your muscles, no better.
I don't have any choice. It is what it is.
It is what it is.
But I just wondered, whether.
Then I would say to you, so if you feel that warm water is taking some of your energy away, just decrease your time spent in the pool, right? So maybe instead of 45 minutes, just think about doing 30 minutes of exercise in the pool. And so that would work the same way. Yes.
But I have to say, exercising, obviously I haven't used my quads for quite some time, and I've been exercising with a physical therapist for 20 years. And they suggested at this point that we go to the aquatherapy. And the first time I got into the pool and tried to do a squat, I went right under.
Oh, no.
But now I can do squats without any problem. And I also do yoga in the pool. And it has helped my balance tremendously.
Yes. So I wanted to touch upon yoga. I did not have time, but there is no research per se with yoga and IBM. But I think yoga is such a great modality for exercise. Yes, definitely.
In the pool, could not do it on land.
No, but you could probably do a little bit in sitting. So some people cannot
that
do
I
in
do.
standing.
That
and
I
in
do.
sitting, they can do some
chair
exercise.
yoga.